sustainable effects than treatment methods focused solely on the individual. It involves, being evidence-based program, it involves a highly structured clinical supervision process and a comprehensive quality assurance process to ensure that the clinicians are adhering to the MST model so that we can deliver consistent, highest quality results. So all of our clinicians have psychology or social work background and are quite experienced in the field before they've moved into their MST role. So how do we address it? So if a young person is using violence in the home, the way an MST clinician would start to understand why they may be doing that is to identify all the potential drivers for that behaviour. Now, this by all means is not an exhaustive list, but it's some of the drivers that we've identified with the families we've worked with so far. So it may be to meet their needs or their demands. They have no other way of expressing that. It may be poor emotional regulation. They may have limited skills to appropriately communicate their needs. The caregivers and young person may not be able to de-escalate or manage anger, so things escalate really quickly. The young person might not be attending school or any pro-social activities. They may be spending a lot of time at home where there is a lot of frustration and conflict within the family. The young person might be engaged with negative peers or gangs where violence is the norm. They may be under the influence of substances, or they may be using aggression or violence to obtain money for substances. The family may also respond aggressively to the young person's aggression, or there's no clear rules or consequences for using violence in the home. So what an MST clinician would do with the family is this is a collaborative process. So they would ask the family, they would ask the young person, they'd ask for all the key stakeholders in that young person's life as to why they feel that the young person might be using aggression or violence. We'd identify then the key drivers, and that's in collaboration again with the young person, with the family, with the stakeholders. And then what we would then do is formulate and implement appropriate interventions that address those key behaviours. So if, say, for example, the driver is no clear rules or consequences for using violence in the home, we'd work with the family in establishing very clear rules and consequences. So that may involve safety planning, that may be in consultation with family violence services. It may also mean using informal supports as well as formal supports to support the family. We would then provide that to the family and we would check in to see how they're going with that. And the intensity of our program allows us to do that. We can phone a family of an evening and say, how's everything going? Are the rules being followed? If they're not being followed, are you following your safety plan? And we can follow up with the family, so we're constantly assessing the barriers and advances to those interventions and making changes if appropriate. If, say, for example, the caregivers and the young person cannot de-escalate or manage anger, it's a whole family approach. So it's teaching the family, looking at the early signs of aggression and violence, and how do we de-escalate? What are those strategies? What are those skills? And working with the family in identifying these are the steps we're going to take when things start to get, the conflict starts. What our aim is eventually we get all the way around that loop. So we eventually cross off a lot of those drivers by putting in different interventions and monitoring those interventions. The idea is then we're promoting treatment generalisation by empowering the caregivers to address the systemic needs of the young person. I've just probably gone through those in terms of they're the steps generally how we address those behaviours. So I just wanted to share with you a case study of a family that we worked with who've completed treatment. So this involved a 15-year-old young woman who was living at home with her mum and two siblings. She had a high level of offending. There was daily physical aggression, including damage to property, absconding most nights, engaging in quite a lot of high-risk behaviours, chronic substance use, mainly ice, not engaging in any education and hadn't done for some time. So after 20 weeks of MST, we saw a significant improvement on multiple domains. So 4 weeks leading up to us closing, there had been no offending, no methamphetamine use, no physical aggression, no absconding, and a substantial reduction in high-risk behaviour. And at closing, we were very, very happy to see that she was enrolled in a training course to commence after a significant absence from school. So this young woman hadn't really attended school since year 7. So this was huge for her, and some of the interventions we worked with this young woman was removing some of those barriers for her schooling, and making sure that we could put in some appropriate supports for her. So over the time we worked with the family, they had over 100 service hours and 45 home visits. So as you can see, it's quite intensive and very, very supportive. And this family used our 24/7 on-call service a number of times, and it was just supporting safety planning. So it may have been, I'm not quite sure what to do in this situation, I need some support. And we were able to step that mum through what needed to happen next.
Just from an implementation point of view, we commenced this, as I said, about 12 months ago. These programs are very resource intensive. You have to ensure you have enough implementation time to get the right people to do it. You have to have enough funding behind it to have the resources to have somebody who is able to be on call, to provide cars or funding for cars, to have phones, to have apps on your phone which allow you to have safety when you're in the home and when you're not. You have to have basically a team leader, thank God it's not me, a team leader who's constantly on call to be able to deal with these things, and we do get call outs. So you're able to sort of wrap around a service. The outputs and what we're seeing, the reduction in these problematic behaviours is fantastic, and the families that we speak to are very engaged with it. One of the big issues we found in regards to choosing the correct families, and I think it was mentioned before, is that earlier on, like when they get to 17 or 18, that they're really less engaged within the family and the caregivers have less sort of influence upon them. And so really targeting those, I'd say sort of 14, 15-year-olds has a larger efficacy in regards to behaviour change. One of the other issues that has come up for us is a lot of families are used to people saying, I'm referring you over to program A, and then somebody will ring you within a month. The integrity of the program is measured on a weekly basis by an external consultant from New Zealand that is overseen by a program which is international. It does not allow us to go into sessions, let's just see how things go, let's just have a general chat, let's have a cup of tea. There are specific goals for each session that are reported on, and if they're not successful, there is a barrier that the clinician has to take back. That is part of the resourcing model. So you have a clinician who is spending at least 2 to 3 hours in supervision every week, going through this session, planning for the next session, looking at safety plan over and over again for a 6-month period. That takes a lot from the therapist point of view, but it also takes a lot out of the family. And I think one of the issues we came about is families expect us to call in a month. We're calling the next day and saying we'll be around tomorrow, and then we'll be down maybe the next couple of days as well. And so ensuring that the caregivers, when we sit down with, say, this is going to be intense, this is going to be very supportive, but we need to get you guys on side because we need to move away from an idea of blame, that it's the kid's responsibility, it's your responsibility, and using a sort of more strengths-based approach is, what are you each trying to communicate to each other, and how can we do that more effectively? That reduces that sort of shame, it reduces that resistance from people of the family saying, well, if you go away, take Johnny and sort out Johnny, then he'll come back fixed, I'll be fine. But equally not saying, it's not your fault the child's like that, it's not the child's fault either. It's actually, faults are relevant. It's a behaviour which we need to manage to reduce harm to the family and create connectivity. The case that we're talking about here, one of the most successful factors was once we put in an absconding plan, then a lot of that, and the child in this case was adhering to it, then their access to drugs and antisocial peers were instantly reduced. So the connectivity, and they were sleeping at night. So the ability to connect with the family the next day was increased. So that was one of the significant points. When you look at a fit circle for we wouldn't have guessed if you put an absconding fan, all of the other stuff will reduce. But that did. But you had to look at all of those variables as well. So what for me, as I'm a forensic psychologist by trade, and I've done a lot of therapy. With young people over the years, and I think what stands out to me most about this model is that the intensity of it keeps the motivation and keeps the traction going, and it keeps the therapist on task. It doesn't allow the therapist to go, we can sometimes feel, oh, look, this family is just too damaged. I don't think we're getting anywhere. It comes back to the therapist. Well, what are you going to try differently? What are you going to try this? Let's try that. Have you tried that? Have you spoken to them about that? Have you spoken to others from community sports? Should we be looking at this from another lens? It keeps that motivation going as well. And since we resource it so heavily, it allows the space and time for them with a low caseload. Maximum caseload for each therapist is 5 families. So 5 children and 5 families. So it allows that space and allows that energy and time to be dedicated to each of them effectively. So if anyone's sitting there wondering, I wonder why this is different, that's my take on it. It's the resourcing and the absolute need to stick to the integrity of the program. And what the evidence says is, if you follow the program within your discretionary psychological skills, of social work skills, if you stick to that program, then the outcomes will come. And so it's drawn back for Kylie on a weekly basis to go back and say, what are we trying? What are we doing? What's successful? What's not? Do we need to change the whole fit circle and try again? That's heavily resourced. That's expensive and heavily resourced, but the outcomes are very good.